Hello, friends. Today, let me continue with the part 4 of hypertensive disorders of pregnancy. And don't worry, I will today conclude it at any cost. So let's not waste time. Let's jump into the topic straight away. And today, I will continue with the strategies of management because yesterday I gave you what are the strategies. Number one is control of hypertension. Number two is prevention of eclampsia by anticonvulsives. And number three, and the final definitive ultimate treatment is delivery. Because we want to take the pregnancy as far as possible to 37 completed weeks, we resort to antihypertensive measures and anticonvulsive measures to tide over the situation. So I was talking yesterday what time to start antihypertensives, whether to start at 140 by 90 or should I wait till 100 diastolic. The CHIPS trial told us that you can start earlier also, that is at 140 by 90, but only thing is that you have to look at the comorbidities present in the person. You should not take the blood pressure to such a low level that the baby would suffer by, as it is, there is vasospasm, vasoconstriction, and blood is not reaching the uterus. So if the blood pressure comes down drastically down during pregnancy, then it will hamper the baby's growth also. So we have to keep that thing in mind whenever we use the antihypertensives. The other important thing yesterday I was explaining is that the drugs that we use in OBG are entirely different from the drugs that they use in internal medicine. So we have to avoid, this is what I think I left with the last slide, but today let me repeat it. ACE inhibitors, ARBs, and direct renin inhibitors, these are the favorites of the physicians, but they are associated with renal anomalies and FGR in the fetus. That's exactly why they are out from OBG armamentarium. So also mineralocorticoid receptor antagonists, that is spironolactone and other drug, they cross the placenta and never been proven safe in pregnancy. So they are also out. What about thiazide diuretics? I told you other day and also during explaining the pathophysiology, there is a situation of poverty amongst plenty. Yes, there is a lot of fluid in the body, but the fluid is in the wrong place. Suppose you use diuretics, which is again one of the favorites of physicians to bring down the blood pressure. It will deplete the intravascular compartment further, and that would hamper both mother's condition as well as it will compromise the fetal condition. So generally, they are not used antenatally in preeclampsia unless there is pulmonary edema, where we may have to use the diuretics on a short-term basis to get rid of the pulmonary edema, because that will endanger mother's health itself. They are used postnatally, however, if hypertension persists, because if you read Williams carefully, one of the reasons for persistent hypertension postnatally, even after the delivery of placenta, is retention of edema. Edema everywhere, both in the periphery as well as in the brain. And that is the reason there is still possibility of a postnatal eclampsia. So in order to control the hypertension postnatally, also to prevent the eclampsia in the postnatal situation, you may use the thiazide diuretics. Now that the baby has been delivered, there is no fear of its bad effects on the fetus. So I hope I am clear. So what about nitroprusside? So it has got limited clinical experience. It's not been used widely. At least in Manipal, we don't use nitroprusside as a method to control the blood pressure. Possibility of fetal cyanide poisoning is very high when you use nitroprusside. That's why we use it as a last resort. As a last resort, if the blood pressure is not coming down by all other means. And you can see the dosage also. It is 0.5 to 10 micrograms per kg per minute. It has to be used using a machine. And it's only used as a last resort. What else? For urgent control of refractory severe hypertension, refractory to other drugs, which I'm going to explain later. And its use should be limited for a short period of time. That's what I said. It is used for a short period of time because it has got the fetal cyanide poisoning effect. And in an emergency situation, see, so many conditions to use this as a last resort, for urgent control, in refractory and severe hypertension, for a short period, and in emergency situation. So might as well not use it. So I say, don't use it, don't use that, don't use this, and use it with restriction and other. What to use then? Of course, now in emergency situation, labetalol has clearly emerged as the drug of choice. It's the first line drug. During my postgraduate days, we were hesitant to use this drug. We were always relying on methyl dopa. The problem with methyl dopa is that it's a very good drug and time-tested drug, welcome in pregnancy, but it acts very slowly. In an emergency situation, that's not the drug to be used, because if I start methyl dopa today, the first action can be seen after maybe 24 to 48 hours. We use nifedipine, all right, but nifedipine has its own limitations, but it's also a useful drug. But labetalol has clearly emerged the first line drug. In an emergency situation, you can use 10 to 20 milligram IV stat, and then 20 to 80 milligrams every 30 minutes, a maximum of 300 milligrams. Till today, we have not been forced to use this 300 milligrams per day. Usually, the BP comes under control with our initial dose and infusion itself. Or you can start with an infusion of 1 to 2 milligrams per minute using an infusion pump. It has got very fewer side effects. That's why it is again the preferred drug. However, it is contraindicated in asthma patients and heart disease patients. Hydralazine. Of course, we don't use hydralazine that often in India, but when I was in Malaysia, we used to use hydralazine. 5 milligrams IV or IM stat, followed by 5 to 10 milligrams every 30 minutes. Or this also can be used in an infusion of 0.5 to 10 milligrams per hour. Again, it has got the same side effects as headache, fetal distress, and hypertension. So sudden coming down of blood pressure is not good for the fetus. It is not good for mother also, but especially fetus will suddenly feel that it is stunned. All this while it was getting nice blood supply, suddenly it appears as though the blood supply has been cut off and it will go into distress. Nifedipine, yes, this has been the drug because its ease of use. It is used per orally, whereas labetalol in emergency you have to use in IV and IV infusion. Same story goes with hydralazine. Whereas nifedipine, the only difference is that now we do not recommend the sublingual usage. Let me repeat this very clearly. We do not use it sublingually. I still see some of them using it, but it is not correct because patients have had severe MI if you used it sublingually. Suddenly the BP comes down and it will be an emergency. So nifedipine has to be used orally. That's why I changed the color to red to make it very clear. 10 to 20 milligrams stat you can give, okay? And repeat in 30 minutes if the BP doesn't come down. Then 10 to 20 milligrams every 2 to 6 hours till the BP comes down to a stabilized level. It also has same headache and tachycardia. So no drug is totally devoid of side effects, but you have to choose your drugs carefully. Asthma and cardiac disease, where labetalol is contraindicated, nifedipine is probably the drug of choice. Now, after controlling the severe situation or an emergency, in order to maintain the blood pressure, or in a non-emergency situation where the blood pressure is moderate in the antenatal period, you can use again labetalol as the first line of choice drug. 200 to 2,400 milligrams per day. Again, that's a maximum limit. We have never used 2,400 milligrams per day in any patient. Maximum we have used 200 milligrams 4 times a day, not more than that. Nifedipine, again, 30 to 120 milligrams per day. That's the maximum limit. Again, I have not used beyond maybe 30 or 40 milligrams per day. That's the max. Methyl dopa, as I said, it's been a time-tested drug, but now it has taken a backseat. In fact, the third position. When it was used in the dosage of 500 milligrams QID. Many people used half-hearted dose, 250 milligrams twice a day, thrice a day. All those things are wrong. If at all you use methyl dopa, it has to be used 500 milligrams 4 times a day, and that's the maximum dose as well. But as I said, it cannot be used in an emergency, and even in a moderate situation. If you use it, don't expect the results within 24 to 48 hours. And once that sets in, then it will, of course, be useful. And it is very, very safe and time-tested drug. The only problem being since it's a centrally acting one, so there can be sudden postural hypertension that has to be clearly told to the patient. Now I go briefly about each of the drugs because that itself can be a question for undergraduate and postgraduates as well. Labetalol has both alpha and beta adrenergic blocking activity. So it may preserve uteroplacental blood flow to a great extent. That's why it has been the choice now. It doesn't hamper the uteroplacental blood flow. And it is more rapid on onset than methyl dopa. Within 2 versus 3 to 6 hours. Sometimes it takes more. Methyl dopa takes more. What else? It has got hepatotoxicity and may confuse with HELP. That's the danger of using any drug for that matter in a backdrop of preeclampsia. So because if you used any amlodipine and things like that, that itself has a side effect of edema and it will confuse you. Similarly, labetalol will confuse you with HELP syndrome due to its hepatotoxicity. Slightly more adverse outcomes such as RDS, sepsis, and seizure when patient was for chronic hypertension. So if the labetalol was used for a long, long time, let's say the patient was a case of chronic hypertension and she developed superimposed preeclampsia and you continue with labetalol, these problems can occur. Although less well studied in pregnant women, pindolol and the long-acting form of metoprolol are acceptable alternative agents. Though these have not been studied extensively, I don't have any experience with these drugs. What about hydralazine as a maintenance drug? Yes, it can be also used orally, not always as an infusion. But the problem is its hypertensive response is less predictable. Suddenly it can come down and you will be in a dire straits situation. So that's why it is not preferred by anybody. However, it causes reflex tachycardia and fluid retention, which limits its usefulness in pregnancy. So that's exactly why nobody prefers this drug. What about nifedipine? Yes, it is very safe and it is immediate release oral nifedipine to acute severe hypertension. Sustained release or long-acting nifedipine can be used for a maintenance therapy. Sparse data on amlodipine because edema confuses. They don't use it. Verapamil and diltiazem also not been used extensively during pregnancy. So it's only few drugs that we have and we have been having good success with that. We don't have to think too much during pregnancy. It's labetalol, nifedipine, and probably methyl dopa will do the job. Methyl dopa is widely used, as I've been telling. Long-term safety is well established. It's been there for more than 60 years, I think. Only a mild antihypertensive agent. That's what is to be understood. It has a slow onset of action, 3 to 6 hours. I've already mentioned that. Many will not achieve targets or bothered by sedative effect. So this is the drawback of methyl dopa. And better outcome than labetalol sometimes. That cannot be forgotten. Clonidine is a cousin of methyl dopa, I should say, in the sense that it is also a central acting drug, antihypertensive. It has got bothersome side effects like drowsiness, dizziness, feeling tired, dry mouth, loss of appetite, constipation, etc. However, it is a drug used in postnatal period once patient delivers because it has got less depressive effect compared to methyl dopa. Because usually patients postnatally can have postnatal blues and depression. And other thing is postural hypertension. To avoid that, clonidine is used. During antenatal period, it is not used. The possibility of rebound hypertension if it is stopped suddenly. That's why usually when we use this, it is tapered. First 4 times a day, 3 times a day, 2 times a day, and things like that. Mostly postnatally when methyl dopa avoided to reduce postnatal blues. That's what I just now said. What about nitroglycerin? As it is, I said, nitroglycerin is not very popular. It has got cyanide type of effect on the fetus. It's an option, however, in pulmonary edema, in the rare occasion when IV diuretics are not effective or cannot be used. Given as IV infusion, as I already mentioned in the earlier slide, 5 micrograms per minute, gradually increased every 3 to 5 minutes to a maximum of 100 micrograms per minute. Okay. Should we also prescribe bed rest along with the medication is the question which has been bothering most of us. As you all know, bed rest has got almost no benefit during pregnancy, except in very few conditions. One of them is preeclampsia. In preeclampsia, if you prescribe bed rest, especially in the left lateral position, the renal perfusion improves, and that's how the blood pressure also comes down. Moreover, higher activity in this particular situation is not good. It may improve uteroplasmal blood flow in preeclampsia and prevent exacerbation of hypertension. However, there is no evidence that it significantly improves major maternal or fetal outcomes. But whatever little it achieves, it is worth it. Otherwise, earlier, we used to see that patients were prescribed bed rest right from first trimester to the ninth semester. It can be counterproductive. It can be harmful. They may get, coagulation, DVT, and things like that. So bed rest is not an answer at all for, most of the problems during pregnancy, except maybe in a case of preeclampsia. And probably, sometimes in the early recurrent miscarriages, if it is due to, certain problems, the patient wants to take rest. That's the time we may prescribe it. But bed rest is no solution for recurrent pregnancy loss also. Probably avoiding intercourse is much more sensible than giving bed rest in recurrent pregnancy loss. It is not recommended in stable chronic hypertension anyway. What about salt restriction? This is another biggest debate that has been going on for years together. Normal diet without significant salt restriction is generally advised. If you restrict salt, it's not really going to be beneficial. In fact, we need salt, in day-to-day diet. Salt restriction may induce low intravascular volume. That is the tragedy. As it is, the intravascular compartment is shrunk. And if you restrict the salt, then that is going to be a big problem. That doesn't mean that you should take extra salt or, you should go out of the way. Magnesium sulfate as an antihypertensive. That's why I put a question mark there. Not as an anticonvulsive, but as an antihypertensive. It is never a substitute for prompt initiation of antihypertensives in severe hypertension, as it has minimal effects on BP. What it means is, let's say you have started magnesium sulfate as an anticonvulsive. Don't think that it will take care of itself. Side by side or simultaneously, you have to also give antihypertensives. Many people ask us, the moment you take a decision to deliver, should we stop antihypertensives? No. The moment we start magnesium sulfate, should we stop antihypertensives? No. All the three are required in a severe preeclampsia or imminent eclampsia. So now I come to the targets. I already explained yesterday that our targets are slightly different from that of physicians. Physicians want to, hit the bull's eye, but we don't want to hit the bull's eye. We just want to probably reduce it, not so much. Our systolic should be somewhere between 130 to 150. That will ensure that the baby gets the blood. At the same time, mother will not be affected. Diastolic should be somewhere between 80 to 100. That's exactly why in CHIPS trial, they said you can start at 85 to 90 also, but make sure that it doesn't go below 80. If the blood pressure is already 80, don't further, continue with the antihypertensives. You always titrate your antihypertensives. So that would affect the baby. The next question is, okay, we understood that we should not hit the bullseye. We should reduce a little bit only, but how fast it should be brought down is another thing. Rapidity by which it should be brought down. It is controversial, but we should understand that cerebral or myocardial ischemia or infarction can be induced by aggressively and drastically and bringing it with speed. That's exactly why sublingual nifedipine is banned. You cannot give sublingual nifedipine. So then how fast we should reduce it? Probably slowly we should hit. not fast like that. 25% over 2 hours. That will stabilize the mother, that will stabilize the baby without hampering its blood supply drastically. So now I come to the second part of the management, which is prevention of eclampsia by using anticonvulsives. I always teach undergraduates that all medical disorders in pregnancy have a single central theme. For example, the central theme of antenatal management in preeclampsia is prevention of eclampsia. The central theme of cardiac management of cardiac disease during pregnancy is to prevent cardiac failure. Same goes for theme of management of anemia is prevention of cardiac failure. The central theme of management of diabetes is prevention of ketoacidosis and macrosomia. So that way, you understand the problem better and you will try to tackle the problem better. Of course, controlling hypertension also goes a long way in prevention of cerebral problems and convulsions, things like that. But to prevent eclampsia, you have to start anticonvulsives. So this is a favorite stock question for all the undergraduates and postgraduates, that what are the signs of imminent eclampsia? Earlier, we used to consider these as only the signs of imminent eclampsia, but most of them, what I'm going to flash, have been already dealt in the beginning of my class yesterday or day before yesterday, when I defined the preeclampsia. Most of these signs are now considered as signs of preeclampsia, not necessarily severe preeclampsia or imminent eclampsia. But traditionally, we said these signs are signs of imminent eclampsia. What is that? In addition to central nervous system, new onset visual disturbances, exaggerated reflexes, and headache, pulmonary edema, I used to come from there, headache, blurring of vision, and then come down, pulmonary edema, doubled AST, ALT, elevated bilirubin, which is because of hemolysis. That is, means you go down to liver and further go down to kidneys, and even low platelets along with this is called HELP syndrome. And then oliguria, serum creatinine more than 1.1 milligrams. So these are earlier considered as signs of imminent eclampsia, but now any one of them, if it is present, it is a diagnosis of preeclampsia. Then what is severe preeclampsia? What is imminent eclampsia? If the blood pressure is persistently more than 160 by 110 millimeters of mercury or higher on at least 2 occasions spread by 4 hours apart. So with any one of these signs, if this happens, then the patient is likely to throw a fit anytime. She's already showing signs of central nervous system irritation by visual disturbances, exaggerated reflexes, and headache, which means indirectly there is brain edema or hemorrhage, pulmonary edema, and liver almost going into failure, HELP syndrome, oliguria, which again shows that decreased blood flow to the kidneys, serum creatinine is more. On top of that, there is persistently high blood pressure, 110 to be precise, and it's been not coming down. That is the time, prophylactically, you must start anticonvulsives. Anticonvulsives should be anyway started when there is eclampsia. There is absolutely no doubt in that. But even if there is no eclampsia, if the BP is consistently high for 4 hours, along with any one of these signs, it's time to start what is called prophylactic magnesium sulfate or prophylactic anticonvulsives. Why I said magnesium sulfate? Because that is the drug of choice. It's the cheapest drug possible, but with the maximum effect. That's why most of the companies do not bother to promote this drug. But it is a wonderful drug. The other story about magnesium sulfate is that when it was used to prevent convulsions in preeclamptic women who are about to throw fits in the preterm situation, and then they of course delivered, these babies, they found that they had better neuronal maturity. That's why they understood that magnesium sulfate can also be used as a neuroprophylactic agent. So it's the eclampsia gave us an idea to use magnesium sulfate as a neuroprophylactic agent. So if the lady is less than 32 weeks gestation, and if she has got severe preeclampsia and about to throw fits, when you use magnesium sulfate for prevention of convulsions, it will also double up. It will also help as a neuroprophylactic agent. So, ek maar do tukda, or one stone you kill two birds. That's how it is. Status epilepticus, you have to use additional. I'm using the word additional diazepam. And whenever you use diazepam, please remember you have to give it very slowly. Otherwise, the patient will die. Long-term use, of course, after tiding over the crisis, for a long-term use, when we give consultation to the neurologist, they would prefer phenytoin or levetiracetam. Magnesium sulfate has got different regimes, but the most popular now in Manipal is Zuspan regime, because this doubles up for neuroprophylaxis as well, especially if the patient is less than 32 weeks, as I said. At 0 hour, you give 4 grams IV stat slowly, of course, and then you follow it up with 1 to 2 grams per hour IV infusion, depending upon the patient size, 1 gram if the patient is not very heavy. Ensure when you give magnesium sulfate infusion, these things to be checked every hour or maybe every 2 hours. Patellar reflex, if they are absent, that means there is magnesium sulfate toxicity. Output should be good. Of course, magnesium sulfate will not reduce the output. Then why should you monitor it? We should monitor it because if the output goes down, the concentration of magnesium sulfate goes up, isn't it? So that is the reason, right? The third thing is, of course, respiration. It's a direct side effect of magnesium sulfate. So if you ask me, direct side effect of magnesium sulfate are only two. One is respiratory rate comes down. So it should be more than 15 minutes. And patellar reflex becomes absent as a direct side effect. But we have to monitor the third thing, that is output also, because when the output goes down, automatically magnesium toxicity increases. So unless the output improves, we should not restart magnesium sulfate. I hope I'm clear. The other traditional regime when I was UG and maybe PG was pit chart regime. That is a 4 gram IV. The problem with this is that you have to give IM also. It's very painful drug, injection rather. 10 grams IM stat, both of them are stat. And then every fourth hourly, 5 grams on either of the buttocks. That's going to be very, very difficult. That's exactly why the Zuspan regime, initial dose also IV, and maintenance is also IV infusion with the IV infusion machine. Here also you have to ensure that patellar reflex is present, output is more good rather, and respiration is more than 15 beats per minute, 15 respiratory rate per minute. Repeat convulsions, what to do? I have already told you injection diazepam is the answer, 10 grams slow IV if patient keeps throwing convulsions while on magnesium sulfate. The last part of the management, or the definitive part of management, whatever you call it, is early delivery, irrespective of gestational age in the event of complications. So in preeclampsia, yes, we would like to save the fetus also, but the priority goes to the mother always. So you will deliver her, or you will think of delivering her irrespective of gestational age, if there are signs of imminent eclampsia or if there are signs of any complications, because you don't want to lose both. By delivering her early, there's a good chance that the neonatologist and NSU will salvage the baby. But if you miss the opportunity, you may lose both. What are the maternal indications? This is another stock question that all the PGs and UGs will be asked. Number one is imminent eclampsia. I have already told you what are the signs of imminent eclampsia, all those lab signs and the physical signs and the blood pressure. Number two, eclampsia itself. Once she has thrown the fit, despite all your good care, despite antihypertensives, despite anticonvulsives, you cannot wait anymore. Some of the old textbooks, the third textbook used to say that there's something called antenatal eclampsia. That terminology is obsolete. You cannot wait once the eclampsia takes place. Abruption, you cannot wait anymore. Abruption active management. Only in placenta previa bleeding, you will give conservative line of management, provided the bleeding is not heavy. HELP syndrome, it is already a sign of imminent eclampsia. Hepatorenal failure independently, without having maybe other signs or without HELP syndrome, is an indication to deliver. Encephalopathy, you cannot wait her to deteriorate further. What are the fetal indications? I have made a rule myself and I'm trying to make it popular. I hope it will stay like that even after me. That is Murli's rule of 5. So what is this 5? If there is severe IUGR in terms of AC less than 5th centile, if the BPP is less than 5, if AFI is less than 5, and any one of the 5 abnormalities in these 5 indicators like Doppler, decreased CPR, absent interstitial flow, reversal of flow in umbilical artery, or MCA, or aortic isthmus, or ductus venosus, where there is reversal of A wave. So any one of these 5 abnormalities and less than 5th centile, BPP less than 5, AFI less than 5, it's a time to deliver the baby. So now we have understood maternal indications and fetal indications. Probably we can put it this way, summarize. After 34, 0/7 weeks, you just don't worry, deliver her if there is a complication. Before that, you have to consider giving steroids. You have to buy time, at least 48 hours or at least 24 hours to give steroids for lung maturity, and then only you have to deliver. If it is before 32 weeks, which I have not mentioned here, you have to, in addition to steroids, give magnesium sulfate for neuroprophylaxis also. And here is the situation, buy one, free one. Magnesium sulfate, you are actually giving for neuroprophylaxis. It will also help you like an anticonvulsive, or other way around also. You are using it as an anticonvulsive, it will automatically take care of the neuroprophylaxis. Decision is not based on proteinuria. When I was PG, we used to say when the proteinuria is more than 5 grams per liter, you have to deliver. So proteinuria is downgraded now. In any case, you don't wait beyond 37 completed weeks. Only in diabetes, we say you may better wait till 39 completed weeks because the RDS rates will come down. Whereas here, it's not just the baby that we are worried about, we are worried about mother. So for the mother's sake, we don't go beyond 37 completed weeks. What is the mode of delivery? This is a very, very interesting question. It depends upon the urgency to deliver. This is a smart answer that I've seen in most of the textbooks, especially Williams. So they don't talk too much. They will simply say, depending upon the urgency to deliver. What is the urgency? Is it obstetrician's urgency? Or is it fetal urgency, or it is maternal urgency? I think it's the maternal and fetal urgency. That's what they mean, not obstetrician's urgency. If mother is going to deteriorate quickly or immediately, she's going to throw a fit, better not to wait. It's an urgent delivery. If you induce, it may take a lot of time, then you may sort of cesarean section. Similarly, if there's fetal distress, I don't have to tell you, it is cesarean section. Secondly, fetal weight. If the baby is less than 1,500 grams, vaginal delivery is going to be dangerous to the baby. So cesarean section is advised. Same goes with the gestational age maybe. Presence of growth restriction. If it is a severe FGR, the baby cannot withstand the stress of labor. So prudent to deliver by section. Presence of CPD, of course, I don't have to tell you. If there is CPD, it is cesarean section. Anyway, that's an obstetric indication, not an indication because of preeclampsia. Probability of successful induction with early vaginal delivery. That's also, if the cervix is uneffaced, os closed, long, and all that, you need time for, first of all, ripening of the cervix, but then you need a time for induction of labor and all that. But what we have seen is in these patients, actually, when there is a stress, if you recall my, don't permit me to talk this again. If you recall my talk on induction of labor, it's the fetal stress due to any reason. Fetus will produce cortisol, cortisol will give rise to CRH, CRH will stimulate the the adrenals to produce substrate to convert them by aromatase enzymes into estrogen. Estrogen will produce prostaglandin. Prostaglandin will produce help the myometrial cells to sensitive to the oxytocin and whole lot of things. Okay, now I am putting the same thing what was there in the previous slide in a different way. Which are the situations you will do cesarean section straight away? Number one, severely growth restricted fetuses. Number two, early preterm fetuses less than 34 weeks who are less than 1,500 grams as well. Fetuses in distress when BPP is less than 5, AFA is less than 5, absent interstolic in Doppler, which I told you very critical. Presence of CPD again, of course, and malpresentation position. If it is breech and preeclampsia, it is called complicated breech, and complicated breech is for cesarean section. Poor Bishop score, as I said, you will spend a lot of time in ripening the cervix, so it is not advisable to go for vaginal delivery. In practice, if I have to summarize, wherever NICU facilities are available with good survival rates for very low birth weight babies, the trend is towards doing cesarean section. In an emergency, of course, not elective. Anesthesia, of course, spinal and epidural is always preferred. What about induction? Is it totally contraindicated? No, not at all. If the cervix is unfavorable and you think that you have time on hand, it's not an urgent delivery, but you want to deliver, you can always use prostaglandin E2 gel and or misoprostol. In a favorable cervix, in fact, you can straight away go for ARM and oxytocin. Here it is, what we have seen usually in preeclampsia, there is some amount of cervical ripening and some amount of cervical dilatation already happening. And ARM will be easy and you can start oxytocin in these patients. But you have to be careful not to overload the patient, especially if she has got pulmonary edema and things like that. Nowadays, misoprostol is the drug of choice for induction. Then only to accelerate, we may go for ARM and oxytocin, and especially ARM to see whether there's any fetal distress, to reconfirm the fetal distress. Similar management with some additions in complications. For example, in eclampsia, management is almost same, but you have to give additional supportive therapy, maybe mouth gag and suction machine and catheter, indwelling catheter and things like that. Maybe sometimes Riles tube feeding. In abruption, in addition to all that I said, you have to also think of DIC and renal failure. In HELP syndrome, in addition to what all I said, you have to also think of platelet transfusion, single or a pooled donor, and you have to also think of steroids. These steroids is not for lung maturity now, that themselves will improve the platelets. Pulmonary edema, in addition to what all I said, you have to think of diuretics and ventilatory support. Postnatally, you have to monitor the BP very closely because it can suddenly come down. Sometimes it may persist. If features of severe preeclampsia are present, then you have to continue antihypertensives. Maybe you can add diuretics now, and you have to continue magnesium sulfate whenever you use it for minimum 24 hours after delivery. And yearly, these patients, you have to monitor the BP, lipids, fasting blood sugar, and BMI, because these patients have got dyslipidemia. Later in life, they may develop hypertension, essential hypertension, and they may develop diabetes, all sorts of problems. Thank you very much for patiently listening to me last 4 days. Of course, there is yet to talk about eclampsia. That's another big chapter and big talk. I will do it some other day. So tomorrow I'm going to Visakhapatnam to give an oration in their CME. That's why no class tomorrow, day after, and on Monday. Instead, I will upload all the classes on YouTube. Thank you very much. Have a great week.